Hello, I'm H.S. Kim from Seoul National University Hospital. I'm a moderator of this session, Satellite Symposium, titled as New Era of AS Treatment and SAPIEN 3's Benefit. This is a 60-minute session having 3 lectures, about 20 minutes per lectures, and then we are going to have discussion time. For discussion, we have 4 panelists: Dr. Jungmin An, Junhong Kim, Philip McCarthy, and Radoslaw Parma. Okay, I'd like to introduce the first speaker, who is Dr. Wonjang Kim from Cha University Bundang Medical Center, South Korea. His title of lecture is Understanding Worldwide Study Guidelines and Where is South Korea Heading to? Dr. Kim, please.
Thank you, Chairman, and very appreciate kind introduction. I just starting my talks. This is my disclosure slide. I'm just starting from the ACC-AHA guideline and the ESG guideline. Last 3 years, we a lot of some guideline updated. So from the ACC guideline, as all of you know, what is some timing of the intervention aortic stenosis is well known about it. And just like the heart failure, aortic stenosis divided D1, D2, D3, and the asymptomatic patient stage C. So which is the aortic stenosis patient, the dual SAPIEN and TAPR. Initially, this patient is dual indicating for the AVR. Initial design and a heart valve team agreement with the patient in a shared decision making. Initial risk assessment, traditionally high or prohibitive risk, well known about it in an STS score more than 80%. Operating measure is more than 2, and organ system and procedure specific impediment in less than 2. According to this anatomic and clinical and life expectancy more than 1 year, in a transparent TAVR paper, we just do at the TAVR. The other one is intermediate low-risk patient, initially vitamin K anticoagulation. Is there any contraindicating? No vitamin K, and initially some adapting of the bioprosthetic, and vitamin is okay. Considering that by age less than 65, mechanical is better. More than 65, bioprosthetic is better. Initially, we choose the biostatic valve, or no concern about a symptomatic very severe AS, T1, T2, T3, or asymptomatic severe AS less than 50%. This patient is suitable for anatomy and the other factor and a transfemoral. We just considering life expectancy. And less than 65% of 5 years in a SAPIEN, and more than 80 years in a transfemoral TAVR is better. Between the two, 65 and the 80 years, the SAPIEN and a transfemoral and TAVR according to some heart team agreement and patient's preference and expectancy. So, what about this guideline including the age? The ACC-AHA guideline and detailed description regarding the age. We have a lot of data in SAPIEN valve deterioration typically occur more than 10 years. So no concern about the efficacy concern is TAVR in the problematic durability. So this kind of valve durability in a patient is a surrogate endpoint of the life expectancy. In the United States, it's a gentleman in the 80 years, the life expectancy is 8. And ladies and 80 years, ladies and remaining life expectancy 10 years. So that's why in a surrogate endpoint. So however, this age breakpoint is not some absolute value. So considering a patient-specific factor and remaining one, some heart team agreement, and then decided should be concerned about the patient's value and preference. So a lot of some risk assessment tool for the surgical valve procedure. Traditionally, STS score and frailty and cardiac and other organ system compromise and prospect-specific impediment. frailty index is already very well known about the Koch ADL plus independence in the ambulation. A major organ is well known about cardiac, kidney function, some pulmonary function test, and so on. So procedure-specific tracheostomy and porcine ascending aorta, chest malformation. The other one is the previous well-known about the Koch index, including the 6 category and essential priority tool set, including the hemoglobin level and serum albumin in some impacting of the some malnutrition. The medical comorbidity and factor predicting poor outcome in a post-TAVI is also considering the factor. So the other one, not of some surgical and just for the TAVI specific risk and fertility while developing in a partner, according to the partner trial and partner TAVI score and French 2 TAVI score and priority and specific, very similar to previous scoring system. However, this is very more useful for the TAVI patient. ACC/AHA guideline, initial clinical factor and valve anatomy, which is factor is Faber sever and which factor is a TAVR. All factors do not agree about that. However, generally speaking, the bicuspid valve, the subaortic LV outflow tract calcification, we so-called in a dagger shape, and pneumatic valve, and an atrial patient is sever is Faber. In a valve anatomy, and the other one, a transfemoral unsuitable for the TAVI, initially designed to some sever. So what about the European guideline? Very similar to previous ACC/AHA guideline. However, in this guideline, the initially assessment of the symptom, symptomatic patient, the intervention likely with the benefit, initially designed to some TAVR. Anyway, some asymptomatic patient is less than 50%. And exercise tolerance is positive, indicator of the adverse prognosis and low crucial risk factor, and considering intervention, which is a SEVA or TAVA. Heart team agreement and using by the old age less than 75 years, it is concurrent to the some low risk SEVA, similar to STS PROM or Euroscore 2, less than 4%, or unsuitable for the TAVA. Transfemoral TAVI, initially considering the SEVER, more than 75 years or unsuitable the SEVER and a suitable transfemoral TAVI, initially considering the TAVA. Between the two, all other patients considering under the shared decision making several TAVI's recommendation. Individual factor, which is factor in several and TAVR, very generally speaking, a higher surgical risk patient, old age, TAVI, previous cardiac surgery also TAVI's favor, severe plaquetty, and also transfemoral approach is feasible, and the other one is some favors TAVA, including in the porcine aorta and chest radiation. So chest deformation also, and you do not agree about that. Anyway, the bicuspid aortic valve initially the guideline excluding the TAVI random trial, so that's why initially some several paper. So this guideline is finally emphasized that the choice of the sever and a TAVR based on the careful clinical, anatomical, and procedural factor by heart team agreement, and then some medical decision making and should be discussed by the patient's preference and value is also emphasized in this guideline. So the very similar previous some table, so I omit this table. So the problem is this the guideline, the risk stratification is problematic, which is a high, which is some intermediate, low risk patient. So the all randomized trial excluding the bicuspid aortic valve is quite different the real world data. I just talk about the small two talks. And old ST score and a new generation ST score, some daily or monthly or some updated by the homepage without any alarm and notification. Don't have any some reply for the some American Society for the reason why this calculation by the statistician. So we adapting our data, Korean TAVI second call registry between 2015-2018, almost all 660 patients, the inoperable high risk patient in 45%. So we recalculating this patient, the initially high 45%. The same patient, we recalculating the last year, we same patient in a high risk patient markedly decreased to 9%, low risk patient is 30% to the some 77 patient. We are quite argument about the same patient has a different score. Is there any change between the two? So that is the problematic. So remaining one in the bicuspid aortic valve, this area is very specific condition. So all random TAVI trial exclude the bicuspid aortic valve and also relatively younger patient and unique anatomic consideration, a large annulus, an asymmetric annular shape, asymmetric calcification, and also aortic aneurysm, the so-called aortopathy. So many chest surgeons arguing about the some bicuspid aortic with the TAVI. So, however, some quite different real world data, we still just do a bicuspid aortic valve. It's just like the some tricuspid aortic valve. 30-day mortality and 1-year mortality, no difference, and stroke is quite similar. Pacemaker is slightly increase in the bicuspid. However, in a discharge in a 30-day and 1 year, there is no difference between paravalvular regurgitation in this real world data. So that's why we intervention cardiologists is different. The tradition, we do not use the different traditional GBOT classification. Almost all patients evaluating the pre-TAVI CT score, CT anatomy. So tricommissural bicuspid valve, we quite similar to tricuspid valve, and bicommissural LAFE, and quite similar. The problematic remaining one is bicommissural and non-LAFE. So considering an clinical and anatomical factor, we just decided to, depending on our precision, just do a several TAVI. So what of the remaining the European and American guideline? Just Canadian guideline 2019, just very similar to European guideline, more than 75 year, 5-year and frailty or limited mobility is favored TAVI. So what of the Japanese guideline? Almost 80 years, there's no change in a guideline. So finally 2020, so Japanese some published in a guideline. So more than 80 years favor TAVI, less than 75 and 7. Is there any including of the ST score in this chart? So patient-related factor and procedure-related are quite similar to the previous two major guidelines. What of the Taiwan coverage indication 2021 and almost some as follows, just one, at least one of the conditions, some national coverage possible. And also the dealing is 80 years old and high risk inoperable patient based on the ST score, more than 10%, and logistic Euro score quite arbitrarily, Euro score 1 is more than 20. And the porcine aorta unable to sever, liver cirrhosis and pulmonary dysfunction. So what of the South Korean, the national insurance data? We have a no change between the 5-year. During the 5-year, we just have a left column in the original Korean article and translate to the right side. We have just the two indicating and which is contraindicating. Indication is vulnerability, symptomatic, severe AS, inoperable in the high risk patient. Both in New York Heart Association 2 and mean pressure gradient 40. Aortic valve area is less than 1.0 centimeter square. Contrary indication is well on our body. So this is a Korean NECA and Korean cardiothoracic surgeon data. So this is what is the most predictive for the mortality after open heart surgery among them the age factor 80 years and kidney function dysfunction and emergent operation is 3 factor is the most predictive factor for the mortality after open heart surgery. So, and even the Korean surgeon is agree about the age factor is very important. So is searched by the Korean statistician government annually report of the lifetime table in a Korean population, general population, quite similar to previous American data. In a Korean gentleman and 80 years remaining 8.4 years of life expectancy, and ladies and 80 years and then the 9.8 years life expectancy. So this based on this data, we got a more than 75 years old age, even in the gentlemen or ladies, is favored to the TAVI in some concurrent to some high mortality of the operation. So I'd like to summarize this one. Beyond the STS score and the Euro score 2, the age factor is more 75 or 80 years is almost very candidate for the some favorable TAVI. So even in the efficacy, no more concern about it. The problematic in the durability concern. That's why in getting low risk patient is including the TAVI and a younger patient and bicuspid aortic health. So considering this kind of the more some development of TAVI in a permanent pacemaker implantation rate and regarding of the parabolic regurgitation is too important to some overcoming a technical issue. The heart team agreement is essential for the decided to several or TAVA. However, we should be shared decision making process in this the decision making with patient's value and preference. But finally, what about the national insurance more focusing on some equity I considering about it. Thank you for your attention.
Thank you very much, Dr. Wonjang Kim, for your nice comprehensive lecture. To the time limit, we are going to move on. The second lecture. The lecturer is Dr. Young-Guk Ko, Severance Hospital, South Korea. The title of this presentation is How is SAPIEN 3 valve design connected to clinical benefit? Dr. Ko, please.
Okay, thank you very much for the kind introduction. As you will all know, SAPIEN 3 is a balloon expandable valve characterized by inner outer sealing skirt, cobalt chromium frame with strong radial strength, and it has bovine pericardial tissue, which is the same material used for the advanced surgical valves. The SAPIEN valve is designed to reduce paravalvular leak. It has the inner and outer sealing skirt made of polyethylene terephthalate polymer, and the inner skirt covers 1/2 of the valve frame, and the outer skirt covers 1/3 of the frame. This is the second cohort of K-TAVI registry data, and this shows the instances of paravalvular leak according to TAVI valves. And SAPIEN 3 shows the rate of moderate paravalvular leak of 2 to 3% immediate after TAVR, and it is definitely lower than the self-expanding valve, the paravalvular leak rates. And the SAPIEN 3 Ultra, which is the next version of the SAPIEN valve, and it has a higher the outer skirt, and it has definitely reduced the instance of paravalvular leak in several early experienced clinical trials. The SAPIEN 3 has a design which provides better access to coronary arteries. The prevalence of coronary artery disease in intermediate and high-risk patients reaches over 50%. And the prevalence of coronary artery disease is lower in the younger and low-risk patients. However, as the patient gets older, these patients, the rate of the coronary artery disease events will be catched up. So it is important to secure the easy coronary access after TAVR for these patients. And according to US Medicare data, about 5% of the patients after TAVR was admitted due to acute coronary syndrome, and at the median time of about 300 days. The most common presentation was an STEMI, and the patients with the STEMI showed the worst prognosis compared to other the acute coronary syndrome the subgroups. The coronary artery cannulation may not be simple as after TAVR as it is for before the TAVR procedure, and the predictors of unsuccessful coronary cannulation after TAVR are known to be the relation between the transcatheter aortic valve and the sinus of Valsalva dimensions, and the implantation depths of the TAVR valve, and finally the valve type, especially the self-expanding valve, showed was the determinant of unsuccessful coronary cannulation because of this higher the frame height. And SAPIEN 3 shows advantage in future coronary access due to its interannular and low frame and large cell design. And inner skirt height ranges between 7.9 to 11.6 according to valve size. And the cell size, which of the cells adjacent to commissure varies from 4.4 to 6.5 millimeters, which are sufficient to accommodate the guiding catheters. This is a re-access study results, which was the single center prospective registry. And in this study, about in 7.7% of the cases, the coronary artery cannulation was failed. And most of cases were self-expanding valve. And for the coronary artery access after TAVR, the self-expanding valve required more time to cannulation and larger volume of contrast media. And I'd like to show a case. This patient presented with an STEMI after 17 months after the TAVR procedure. And this was the angiogram at the time of the TAVR. And there was no significant stenosis at the left main. And however, at the repeat admission, the patient showed significant narrowing at the left main. And the coronary ostium was located higher than the TAVI valve. So it was not difficult to engage the left coronary artery. And also the procedure, stenting procedure itself was not that difficult. So we successfully treated the patient with coronary stenting. And this was the final result. Also, the SAPIEN 3 design lowers the instance of AV conduction disturbance. And there are the risk factors for the conduction disturbance after TAVR. And then these are the patient-related risk factors, which include age and low LVEF and smaller LVOT and pre-existing conduction disturbances, etc. And also there are procedure-related risk factors such as depth of valve implantation and mismatch between LVOT and valve size, so the oversizing, and the predilation, and the self-expanding valve type, which is usually implanted deeper and which has more oversizing. And also the membrane septum length is important. There is an inverse relationship between membrane septum length and the risk of AV block. The difference between MS length and the implantation depth is the most powerful predictor of pacemaker implantation. And this is the pacemaker implantation rate after TAVR using newer generation prosthesis. And the rates shows variable across the clinical trials. But in general, SAPIEN 3 shows lower pacemaker implantation rate compared with the self-expanding valve type. and the pacemaker implantation rate was 6.5% in partner 3. There is more instance of new onset LVB after TAVR compared with complete AV block. The incidence ranges between 15 to 75% across valve types. The clinical impact of new LVB after TAVR remains controversial. However, in partner 2 trial, the new LVB was associated with increased instances of all-cause and cardiovascular deaths and increased rates of rehospitalization. So it is important to avoid any kind of AV conduction disturbance. And also SAPIEN 3 is designed to make safe delivery of the valve possible. It helps to prevent major vascular complication. It has expandable sheaths, which makes the safe delivery of the valve more possible. And also it improved the delivery profile compared to previous version. And the delivery catheter has the possibility of a dual articulation, which helps to cross challenging anatomies and to control valve coaxiality. This study investigated the impact of the aortic angulation on TAVR outcomes, and it compared low aortic angulation and high aortic angulation for the procedural success and the number of valve used and instance of moderate or severe paravalvular leak. Study found no significant difference between two groups regardless of valve type used for TAVR. However, in our experience, horizontal aortic route showed difficulty for the delivery of TAVR valve. This patient had the bicuspid aortic valve and the ascending aorta was dilated. In this patient, we had the difficulty to deliver aorta delivery catheter. So with some effort, we was able to deploy the valve. However, after the final deployment, we found dissection of the ascending aorta, and this patient required emergent surgery. And this patient showed localized dissection at the distal aortic arch, and so we have to be very careful with the delivery of the valve catheter. So in this patient, we used SAPIEN 3 for the TAVR, and we advanced the delivery catheter with flexed tip. And with this approach, we did not contact the aortic wall. So we finally deployed the valve successfully, and we found no aortic injury after the TAVR procedure. And the SAPIEN 3 showed excellent clinical evidence in low-risk patients, and this is the partner 3 primary endpoint. And the advantage of the SAPIEN 3 design was successfully translated in excellent outcome. And in this study, SAPIEN 3 showed a significantly lower incidence of primary endpoint. And in all second endpoints, also SAPIEN 3 showed better outcome compared with surgical AVR. Finally, if we consider future TAVR and TAVR in patients undergoing TAVR, so SAPIEN 3 may be more advantageous in terms of better coronary access. We can 4 kinds of possible conditions for TAVR and TAVR procedure, especially when we implant the self-expanding valve as first valve. Then it develops a longer narrow skirt, which is produced by the leaflets of initial valve jailed by the second valve. And if we consider this situation, the initial self-expanding valve as a first valve showed the highest instance of no access for the coronary intervention. So these are my take-home messages. SAPIEN 3 was associated with low instance of probable leak, and AV conduction disturbance, which may have adverse impact on long-term clinical outcomes. The clinical benefits of SAPIEN 3 was well demonstrated in Partner 3 trial with low surgical risk patients. SAPIEN 3 enables future coronary access easier due to the low frame height and larger frame cell size, especially when you consider coronary access after TAVR and TAVR, especially first balloon expandable, where TAVR is more advantageous than the first self-expanding TAVR. The SAPIEN 3 should be preferred in younger and low-risk patients undergoing TAVR unless other factors favor other valve types. Thank you for your attention.
Great, thanks for your wonderful lecture, Dr. Young-Go Ko. The third speaker is Dr. Giuseppe Tarantini from University of Hospital Padua, Italy. The title of his lecture is SAPIEN 3 a step further on from lifetime management, BAV, FCA, and VIV? Dr. Tarantini, please.
Thank you. Thank you. First of all, thank you for having me. It's a big pleasure to be part of this meeting. So as you can see, my task is to discuss the role of SAPIEN 3 in a setting of lifetime management. This is my disclosure slide. So actually, to avoid unnecessary complication related to the lifetime strategy, I created this slide just to highlight the concept that we have two main aspects to consider when we discuss about the lifetime strategy with each valve in the market. That is the life expectancy and also the THV durability on the other side. So actually sticking to the point, THV durability with a specific focus of the SAPIEN, what we know by the Partner 2 trial 5 years result of structural plus biprosthesis valve failure, actually we know that we don't have any difference compared to the surgical valve. We have a few data also related to the core valve at 8 years with the Notion 2 that replicates the same concept, that the valve durability with the last generation valve is not an issue. But actually, with this background in mind, I think it's easier to understand the following. So we have to admit that we have two very different clinical scenarios. The one on the right-hand side of this slide, that's a patient that is octogenarian, so 83 years old. In this patient, the THV durability is also, invariably longer than the life expectancy of the patients. So actually, we can close the door of this kind of patient, as we've seen in the previous presentation. TAVI is the first line approach in this patient. But we have other clinical scenarios. The one with a tricuspid valve that is on average 72 years old, and this is the age of the low-risk trials, that is both Partner 3 or low-risk core valve trials, but also bicuspid valve patients that is on average 65 years old. In this case, this is the opposite of the previous scenario. The THV durability might be shorter than the life expectancy of the patients. So mainly focused in the latter scenarios, we have to think about the lifetime strategy. That means not only to select which is the best treatment in terms of surgery versus TAVR as first attempt, but also we have to think ahead to the second and possibly to the third intervention in the lifetime strategy of this patient. Let's start from the scenario of the patient that is more than 75 or 80 years old. This is an editorial that I published on JACC Intervention a few months ago. So I think that the door is closed in this regard, because we know that the first intervention has to be TAVR according to the S guidelines, but also according to the American guidelines. And actually, related to the second intervention, we might discuss if we have to go for TAVR in TAVR or TAVR explantation SAV. But again, based on the evidence that we have so far, also the second intervention is TAV, that is related with a 50% reduction in mortality compared to TAV explantation. So when we deal with patients older than 75 or 80 years old, the story is finished. To look as a first choice to the TAV, and also in the second attempt, we have to repeat the TAV. More complex is the situation for patients between 65 and 80 or 75 years old, or even younger. So in this regard, we have to discuss very accurately in the heart team, which is the best treatment. Actually, we have to discuss about TAV or SAV, and we have to consider all the anatomical factors that my colleagues has presented previously in the previous presentation. And actually, the question of the organizer to me is how to keep all options for the future in younger, lower risk patients. So we have to discuss in our team if the SAV is the intervention, what type of SAV? What type of surgical valve? Secondly, if we decide for TAV, we have to discuss ahead for these patients, what type of THV. We have to look at the coronary obstruction risk and the conduction disturbances risk, and also in perspective to the risk of TAV in valve that might be TAV in TAV or TAV in SAV. So let's start from the first point. Related to the SAV, I will go fast forward just to highlight that not all the valves are coronary friendly after TAV valve. For instance, externally mounted leaflets or stentless has a risk of occlusion after TAVI that is 3 times, 4 times higher compared to the gold standard surgical valve. So we need to keep in mind and to discuss in the heart team. And actually also, if the TAV is the first intervention in a younger patient, we need to know that based on these 3 different experiences, one is Padua, the other one is US, and another one is European. In 2/3 of cases, the supraannular valve create impairment in the coronary access, that is not exactly the same rates that we have in case of balloon expandable valve like 3, that is only 1/3 of cases. And this is a quite remarkable data because it's consistent and reproduced in many, many papers. Actually, there is an importance to be subcoronary. We don't have to think like the surgeon, to be supravalve, supraannular, annular, intraannular, but the concept is to be subcoronary or supracoronary. For instance, with the core valve, we are below the commissure, with the commissure, below the right coronary artery, only 7% of cases compared to 40% of cases for the SAPIEN valve. And actually, we have another to consider, that we have to orientate the valve in case of self-expandable valve. Because as you can see, the skirt is asymmetric. We have a tent that is 26 meter height compared to the 13 millimeter height when you orientate the valve. But it's not always possible to orientate the valve. And actually, we have challenges in coronary access that might be the fact that this valve is supraannular, and actually the SAPIEN 3 is intraannular, so we don't have problem. Related to the height of the skirt, again, the SAPIEN 3 do not have this problem because the skirt is very low and is very symmetrical. It's very even around the circumference of the valve. Actually, we don't have closed cell like the core valve. We have an open cell design, so we don't have this problem related to the core. And finally, related to the valve in valve, we don't need to orientate the valve. We stay with the valve in valve. We may discuss on the final gradient, but we can discuss, during the discussion. But we don't see any problem in this regard. So actually, this is the biggest European registry that we published in Circ Intervention 2020. And we show that the SOS3 registry, the coronary access with the SAPIEN was 100% feasible, and the PCI was feasible in 98% of the cases in 2,000 patients. This is the reality of what is happen, in Europe. And actually, this has been published 2 weeks ago from my group just to demonstrate that when you compare 2 self-expandable valves, this is core valve and the accurate balloon expandable valve, and you orientate the valve, you may increase from 46% to 71% the coronary access, but you stay far away from the 95% of the coronary cannulation that you can get implanting the SAPIEN 3, because you stay below the coronary artery. So let's move forward towards the conduction disturbances. We have a head-to-head comparison, but this is a summary of all the evidence available in literature. And actually, if we just spot and try to look at the lowest rate of pacemaker did belong to the partner and partner 3, that is below 6.5%. And actually, when we look at the self-expandable with a better outcome in this regard, we have the accurate, we have the portico, we can see also the core valve, but actually it's should to have a step up compared to the shorted valve, balloon expandable valve in terms of final pacemaker rate. And this is related to the predictability, to the fault of the THV, and the fact that you don't need to oversize the balloon expandable valve. The last point that is very, very important in perspective is related to the second type of intervention. So what about TAVR in SAVR? Actually, in Europe, the two global leaders that have the CE mark for TAVR in SAVR are the core valve family and the SAPIEN family, and SAPIEN 3 actually. We, together with Tang and Veer, we published on your intervention a few weeks ago, a review that tried to, to look at all the aspects to consider when you go with a valve-in-valve that are patient selection, procedure, pre-procedure planning. But just to summarize in slide, not all valves are the same. For instance, in blue, here you have a surgical valve first. When you decide to go with the second TAVR in surgical valve, as you can see, when you go with the balloon expander, you don't have to orientate the valve. Many times you stay below the coronary artery. On the contrary, when you go with a self-expandable valve, you stay always with the skirt above the coronary. So what is extremely important on the right-hand side of this slide, to orientate the valve. This is a real case from my institution. For instance, when you go with a core valve in a non-oriented way, you can see it's, on the left-hand side, it's possible to cannulate the artery. Actually, on the right-hand side, we weren't able to orientate the valve, and we went in front of the coronary ostium with a 26 millimeter. It was not possible to cannulate the artery anymore. So we have to consider all this part. What about TAVR in TAVR? Actually, we have two registries with total different outcome, 30-day mortality 1% versus 7%. Actually, there is also a different distribution in the redo TAVR registry. 50% were balloon expandable valve. On the contrary, in the transit registry, 61 were self-expandable valve. It's not possible to make any inference related to the type of valve and outcomes, but actually we need more science to be conclusive in this direction, and mostly we need data on the durability of TAVR in TAVR, because absolutely we don't have any data in this regard. But actually, we need to be very fair to say that in Europe, the only valve that has the CE mark for TAVR in TAVR is the SAPIEN valve, and not the other valve. So in conclusion, what about TAVR explantation? Because actually, you know that when we deal with the first attempt with the TAVR in a 65 or years old patients, we might need in a high likelihood second intervention. So sometimes there is the need to remove the TAVR. And actually the two valves are not the same, because again, if you look at the need for a second aorta replacement, there is a significant difference between the balloon expandable SAPIEN compared to the core valve. That is significant, because when you have a taller valve at 1 year in this paper, it is clear that you have the struts that are embedded within the wall of the aorta, and you have to replace and to go on any other solution that's complicate a lot all the things. So going back to my editorial, so we know that one thing that we deal with a younger patient and we decide to go for TAVR, based on the IFU and the CE mark in Europe, there is no age limit for SAPIEN. There is age limit for core valve, that you need to stay above 70 years old patients. When you go for second intervention, you decide for TAP, you might, ask for all the valve you want, but actually we have to admit that the CE mark for the moment, 2021, 2022, stay in the SAPIEN 3 family. Related to the third intervention, we don't have any data. So toward the conclusion, just 3 slides. 3 slides is the bicuspidity. This is another review published on silk intervention from the university. And actually, I just want to report this, registry that is 1-to-1 propensity score matching. 3,000 versus 3,000. Actually, the primary endpoint was death stroke at 30 days and 1 year. As you can see, there is a quite, a neat result between bicuspid and tricuspid valve. Actually, there is really a tiny difference in terms of pacemaker rate and PVL. It is, in the order of 1.8 versus 1.1. But when you look at the residual gradient, was really similar between the bicuspid and tricuspid valve anatomies. So again, for both valves, for both the global leaders, we have a CE mark that actually like to spot the fact that only for SAPIEN there is the CE mark approval in bicuspidity for low-risk patients. That is not present for valve. So in conclusion, my dear friends, whole patient with severe aortic stenosis might be discussed in our thinking, the lifetime strategy, mostly in younger patients. When SAVR is the first choice, remember that not all the prosthesis types, surgical prosthesis types, are going to be TAVI friendly. Secondly, when TAVR is the first choice, not all the THV are the same, and the THV class effect is really unlikely. And the SAPIEN 3 seems to be the best in class for younger and lower risk patients related to future coronary access, pacemaker rate, and valve intervention. So just for the discussion, this is my take-home message. Who's the GOAT? I'll leave you the decision. Thank you for your attention.
Thank you very much for your wonderful lecture, Dr. Tarantini. Now we have about 10 minutes time for discussion. We have 4 panelists, Dr. An, Kim, McCarthy, and Parma. Do you have any comment on the previous 3 lectures? Brief comment, please.
I can start by thanking my colleagues for some excellent presentations. I think it's taken us quite a while to come around to this way of thinking, but it's really, really important, I think, in all aspects of valve disease to plan lifetime strategies, not just with TAVI, but with young women, with mitral rheumatic disease and everything else. So this concept is a bit late coming to us in the valve world, but we need to plan the whole lifetime of the patient. And Giuseppe's talk nicely illustrates that you have to think really hard with the first intervention down the line. It seems hard to think 10, 15 years in advance, but it's vitally important, and you can make that patient's life hugely better if you do that and you put in an appropriate valve the first time round. We desperately need durability studies, and we desperately need some guidance on how valve-in-valve behaves, particularly with regards to pharmacology, because no one really knows what kind of antiplatelet and anticoagulant therapy these patients need to be on. I still don't know myself. So we desperately need to be recruiting to studies to look at durability and pharmacology to help our patients.
Regarding the choice of TAVI valve for younger patients, previous lectures suggest SAPIEN may be superior to Avalot because easier coronary accessibility in the future, the patient may need PCI. And the other one is, as the first valve, SAPIEN is better for the future TAVI and TAVI. So we can agree with SAPIEN may be more appropriate for younger patients than Avalot. But in terms of durability, the orifice area is very important to determine the structural valve degeneration. As you may know, orifice area is greater in Avalot than SAPIEN. Thus, in terms of durability or functionality, to determine SVD, Evolut may be preferable to SAPIEN. In terms of thrombosis in valve frame, there is a subtle difference, a little bit higher thrombus formation around the SAPIEN valve. Thus, in this kind of conflicting aspect, how do you think about the real choice of TAVI valve for younger patients? Dr. Tarantini, do you have any?
Yes, I'm really glad to reply. I didn't understand if it was for me. Actually, this is a very, very important question, but I can tell you one thing. We don't have an head-to-head comparison at 10 years between the two valves. Actually, there is still the embargo, but we submitted the paper comparing these two valves in a very large Italian population. What I can say to you, that when you look at Vibros BVF, that is fibrosis valve failure, that is, you have to look not only at the gradient, but also on the clinical aspects. There is no difference. There is some difference in terms of the final gradient. That is a little bit lower with a core valve, but nobody knows if having a 5 millimeters of mercury difference matter a lot in terms of clinical gradient. On top of that, we have to admit that in perspective, when we go with the self-expandable valve, we have to think at some, devices that cut the leaflets. Otherwise, it's going to be really a mess for the coronary access when you go with the TAV. And actually, if you go with another self-expandable valve, it's not anymore matter of the orientation, because when you tilt up the leaflets, you create a kind of covered. And this is not the case when you go with the SAPIEN valve. So I'm not saying that we have the data, the final data, but actually on the bench, we look at the frame, at the design, also the engineeristic aspect of the valve, it seems that the new generation valve need to be shorter when, thinking at a younger patient. But actually, we don't have to invent anything, because when we look at the surgical valve, all the surgical valve, the vast majority of the case below the coronary. And we have to think about that.
Okay, is there any comment from the panels?
I have a question. As you all know, the intra-annular, the balloon expander valve shows smaller effective valve area after TAVR, and also it shows higher pressure gradient compared to self-expanding valve. So, do you think it has a real impact on the in the choice of the valve type in young patients, maybe with small annular size?
This is another very important point. I don't know, Philip, if I'm supposed to answer, but
yeah, I was going to say that is true. The hemodynamics are different, but actually there's no clinical correlate to the hemodynamics. And in fact, if you look at large numbers of patients out to 8 or 10 years, those initial post-TAVI hemodynamics don't correlate with a poor outcome. In fact, in some large series, they correlate with a good outcome using the SAPIEN valve. So no one has been able to correlate post-implant TAVI gradients and hemodynamics with any kind of clinical bad outcome. And it's the same with PPM as well. So there's a lot we don't understand here, but certainly those slightly higher gradients don't translate into clinical events.
In this,
can I say something very quickly? So what said Philippe is extremely important. So there is not a strict correlation, direct correlation between the final grade, even with 20 millimeter of mercury as a residual, that by definition is an SVD, that means a structure valve degeneration. Actually, you don't see an increase in worse outcomes, etc. But please just let me say something that is important. When you have a small annuli, you have also a small STJ junction. So when you go with a supraannular valve, if you have by chance an early degeneration of self-expandable valve after 3 to 4 years, you need to explant the THV, because it's very difficult to go with the TAVR for the risk of the impairment of the coronary access. This is something that we need to keep in mind, that we can think 3 to 4 millimeters of mercury in terms of increase of the final gradient, but actually, if we have an early degeneration or a very tall valve, we have a real problem how to treat with a TAVR these patients.
I think orifice area is very important for us to choose a valve in VF-TAVI. There are two kinds of VF-TAVI, TAVI or TAVI failed surgical valve. When we consider TAVI failed surgical valve, we always choose Avalot because it provides bigger orifice area, especially in small failed surgical valve. It is really necessary to get as larger, as wider orifice area as possible. But in terms of TAVI, we usually consider SAPIEN because, as mentioned by Dr. Tarantini, when we deploy the Avalot in failed Avalot valve, there are really multiple layers that may obstruct ST junction and really deteriorate the coronary flow. Thus, I think we should emphasize the different situation, even in the same VF-TAVI.
This was actually one of the clinical issues I wanted to emphasize, that for the treatment of TAVI in TAVI, so the patients with degenerative TAVI prosthesis, it can be stressed that SAPIEN 3 appears to be the optimal device, just protecting the coronary access in many of the currently or previously used TAVI prosthesis. And also, I would like to point to patients with large annuli in whom we need to address the full sealing and the lack of paravalvular leaks in this population. I think that with the amount of SAPIEN 329 coverage, I think it can be safely used to address most patients with fine leaflet aortic valve anatomy, but also with usually large annuli with of a bicuspid anatomy. So these two clinical scenarios are also important to think about, and they can be safely addressed with this THV.
My final question is, do you really, the TAVI indication is depending on the age or surgical risk? Because in previous guidelines, there is a subtle sentence suggesting TAVI may be preferable for patients with high surgical risk. But actually, landmark clinical trials showed in high surgical risk patients, TAVI's performance is very similar to SAVI. So TAVI is not superior to SAVR. In our cohort registry, Korean TAVI registry, the mortality in high surgical risk TAVI is about 15%, 2 years, but 3% in low risk TAVI. Thus, I think if surgical risk is high, TAVI risk is also high. When you consider low risk patients, when you compare TAVI and SAVI, TAVI is superior to SAVR, at least in Partner 3 trial. Thus, actually, TAVR may be preferable in patients with low surgical risk patients. But still, many physicians theoretically, just conceptually, think about TAVI first in high surgical risk patients. So how do you think about such kind of ironical, not kind of right thinking process in physicians?
Can I say something? Just 10 seconds. I think to this point, Kim, recently has been published a great registry, surgical series in US. And I was struck by the fact that when you have a patient of intermediate and high surgical risk, invariably, the survival curve was below 10 years. So what means to me is that whatever is the age of this patient, stay at intermediate to high surgical risk, for me it's better to go for TAP. On the opposite, in this surgical series, you have patients that has a low surgical risk. When the patient has more than 75 years old, the survival rate was always below 10 years. So actually, I would say that TAV for me is going to be the fair choice, because when you have a life expectation that for 10 years, I don't see any reason to go for surgery. What is different is when you have a patient, a low surgical risk and below 75 years old. And as Philip said before, we need more science, longer follow-up, etc., to understand if this is the way to go.
Usually, youth is associated with low surgical risk. So many physicians confused about age and surgical risk.
Yes.
So we have to separate surgical risk and age. Okay, thank you very much for your wonderful contribution. Now time's up, so I'd like to close this wonderful session sponsored by Edwards Life Science Korea. Great, thanks. Bye-bye.
Thank you very much.
Bye-bye.